Thank you to the ATS conference organizers for the opportunity to present this talk on airway provocation to define exercise-induced bronchoconstriction. I have no relevant disclosures. This presentation is based on the new ATS clinical practice guideline on EIB. Attendees will be able to describe the latest challenges to evaluate EIB. This presentation will consider diagnosing, screening, measuring, and quantifying EIB, exercise and EVH challenge demonstrations, evaluation of patients suspected of having EIB, and surrogate challenges. EIB is the preferred term. Diagnosis of EIB should be based on change in lung function after exercise and not on symptoms. Symptoms associated with exercise, such as shortness of breath, cough, wheeze, and mucus production, are neither sensitive nor specific to identify EIB. Among athletes, EIB can be seen in individuals without symptoms associated with exercise, and many individuals with respiratory symptoms associated with exercise do not have EIB. Rupp et al. Performed pre-participation physical examinations in 166 middle and high school athletes, ages 12 to 18 years, who completed questionnaires, interviews, and PFTs. Then the investigators performed resting spirometry, treadmill challenge, and PFTs at 1, 10, 20, and 30 minutes following exercise. All students were challenged regardless of history or baseline PFTs. 22 of 166, or 13% of the athletes, had greater than 15% fall in FEV1 on the treadmill. Of students at risk, that is history positive or baseline PFTs abnormal, 8 of 48, or 17%, had EIB. Of students not at risk, that is no history or abnormal baseline PFTs, 14 of 118, or 12%, had EIB. The conclusion is that 2/3 of athletes with EIB would have been missed based on history and baseline PFTs. Serial lung functions are also used to quantify severity of EIB when present. FEV1 and not peak expiratory flow rate should be the endpoint because FEV1 is more reproducible. Recovery from EIB is usually spontaneous. FEV1 returns to within about 5% of baseline within about 30 minutes after exercise in most patients. According to ATS guidelines, at least 2 reproducible FEV1 values should be determined at each time point, with the highest acceptable value recorded typically 5, 10, 15, and 30 minutes after exercise. Full FVC does not need to be determined and should not be measured to avoid tiring the patient. A fall in FEV1 of 10% represents the mean plus 2 standard deviations of the percent fall in FEV1 in normal healthy subjects. Higher values for percent fall in FEV1 to diagnose EIB have been recommended. A fall in FEV1 of at least 10% at 2 consecutive time points following exercise, or a fall in FEV1 of at least 15 to 20% following exercise, or even 2 positive challenges. Severity of EIB can be graded as mild, moderate, or severe if the percent fall in FEV1 from pre-exercise levels is between 10 and 25%, between 25 and 50%, and greater than 50% respectively. Let's examine a typical exercise challenge. This video clip describes briefly the conduct of a standardized exercise challenge in a clinic or pulmonary laboratory. This laboratory exercise challenge is consistent with ATS guidelines. The challenge requires some, but not an excessive amount of special equipment. Equipment includes a medical-grade treadmill, an H or K-sized tank containing medical-grade compressed air, a balloon reservoir, a mouthpiece or face mask with a saliva trap, tubing, a monitoring device, and a spirometer. Briefly, the regulator on the gas tank is connected to the balloon reservoir. Tubing from the balloon reservoir is connected to a low-resistance, low dead space breathing device. The exercise challenge should not, in general, be performed in patients with baseline FEV1 that is below 70% of predicted. First, the pre-challenge spirometry is completed and the data are reviewed. The target heart rate is calculated, as is the alert value for the fall in FEV1 and the 90% recovery value. Then the challenge starts. The patient begins to inhale the dry air while walking on the treadmill at 2.5 miles per hour and a 2.5% incline. The target heart rate is 80% of maximum, achieved within 2 minutes of beginning to walk. Air is maintained at 20 to 22 degrees centigrade. Heart rate, SpO2, and electrocardiogram are monitored. The incline and speed are adjusted to assure that the heart rate is maintained at 80% of predicted maximum, for the remaining 6 minutes. A total of 8 minutes of exercise is performed. As demonstrated, this is a strenuous test with a much faster ramp up to 80% of maximum heart rate than with a Bruce protocol cardiac stress test. Moreover, the exercise challenge is completed much more rapidly than a stress test so as to avoid the refractory period. At the end of the challenge, post-challenge spirometry is performed at specified intervals such as 2.5, 5, 10, 20, and 30 minutes. Usually only FEV1 and not full FVC maneuvers are performed. In the clinic, a positive test usually requires a 10% fall in FEV1, although higher falls may be required in pharmaceutical trials. The following may be adjusted in performing this test: the temperature of the inspired air, the maximum heart rate, and the duration of exercise, which usually should not exceed 8 minutes total. The patient can then be treated with rescue albuterol until the FEV1 returns to at or above 90% of the baseline FEV1. Laboratory challenges are much more controlled than free run tests, but do require this special equipment that must be maintained. When properly performed, a laboratory-based exercise challenge can provide important objective data to demonstrate obstructed airways associated with exercise. It is preferable that the subject use a nose clip while performing the exercise challenge. The main determinants of EIB are type, duration, and intensity of exercise, sustained high-level ventilation during exercise, temperature and water content of inspired air, and time since the last exercise. Some subjects become refractory to another exercise stimulus for 2 to 4 hours after the first exercise is completed. The ventilation required for a valid test should be at least 17.5 times FEV1 at baseline and preferably 21 times baseline FEV1. Measurement of ventilation during EIB testing permits comparisons of the effect of the same stimulus over time in between subjects. Heart rate is often used as a surrogate measure for intensity of exercise, although the relationship between heart rate and ventilation varies widely based on the patients being studied. Let us examine how the ATS guideline addresses the diagnosis of EIB using the top of this figure from the ATS guideline. In a patient presenting with symptoms suggestive of EIB, the first step should be to obtain a history and determine if the symptoms suggest EIB. Then, if symptoms suggest EIB, the patient should undergo an exercise challenge. If the challenge is positive with a fall in FEV1 of 10 to 15%, then the diagnosis of EIB is confirmed. If EIB is confirmed, then treatment should be initiated. If the diagnosis remains unclear, then exercise challenge might be repeated. If the challenge is negative, then alternative diagnosis should be evaluated. Some exercise challenges have been identified that may serve as surrogates for exercise. Eucapnic voluntary hyperpnea or hyperventilation, inhalation of hyperosmolar aerosols of 4.5% saline, and inhalation of dry powdered mannitol. No surrogate challenges approach 100% for either sensitivity or specificity to identify a person with EIB. An EVH challenge is one such surrogate challenge that may be considered in place of an exercise challenge. This video clip describes the conduct of an EVH challenge, eucapnic voluntary hyperpnea, which is a substitute for exercise. EVH was originally developed and validated by the U.S. Army as a surrogate test for exercise-induced bronchoconstriction. Although the EVH challenge is less commonly used than an exercise challenge in the U.S., EVH is strongly recommended by members of the Medical Commission of the International Olympic Committee for testing of elite athletes to determine if they have bronchial hyperresponsiveness. EVH is included in the World Anti-Doping Agency assessment of asthma at the website listed on the screen. EVH uses hyperventilation as a trigger for EIB and correlates well with EIB in trained athletes. EVH requires some, but not an excessive amount of special equipment. Most notably, EVH requires a gas tank that contains a mixture of medical-grade air containing 4.9 to 5% carbon dioxide and 21% oxygen, with the remainder of the gas being nitrogen. This mixture is necessary to keep CO2 levels in a constant range over a wide range of voluntary hyperventilation. Briefly, the regulator on the gas tank is connected to plastic tubing that is in turn connected to a rotometer and then to a balloon reservoir. Tubing from the balloon reservoir is connected to a low resistance, low dead space breathing device. The tank, tubing, and required devices can be set up rather easily. As with all bronchial provocation challenges, the EVH test begins with a patient providing a consent. Then the patient is evaluated to assure that he or she is capable of performing the test and that the test is safe to perform. Drug washouts are examined to determine if the test is valid to perform as well. The EVH test should be performed with caution in patients with FEV1 that is below 80% of predicted at baseline and should never be performed on patients in whom this FEV1 is less than 70% of predicted because of the danger of severe bronchoconstriction from the challenge itself. Once the pre-challenge spirometry is completed and the data reviewed, then the challenge may begin. The patient inhales the gas mixture maximally with a target ventilation rate of between 22 and 30 times the baseline FEV1 in liters per minute. Air is usually maintained at between 20 and 22 degrees centigrade. Pulse oximetry is simultaneously performed with the challenge. At 30 times the baseline FEV1, the patient will be breathing at about 85% of maximum voluntary ventilation, or MVV. The maximum inhalation continues for a total of about 6 minutes. The following may be adjusted in performing this test: the temperature of the inspired air, the ventilation rate at which air is inspired, and finally, the duration of inhalation. Competitive athletes, especially highly trained competitive athletes, may be pushed to the limit in performing the test. Now, following the 6 minutes of breathing, the subject performs post-challenge spirometry at 1, 3, 5, and 10 minutes, which is examined to determine if there is a fall in FEV1. The patient can then be treated with rescue albuterol until the FEV1 returns to at or above 90% of the baseline FEV1. It should be reiterated that EVH should never be performed on a patient who has an FEV1 below 70% of predicted, and only with caution in a patient with an FEV1 below 80% of predicted because of the risk of a serious fall in FEV1. Nevertheless, when properly performed by trained specialists, the EVH challenge can provide valuable information about individuals who are suspected of having EIB, but for whom the objective data are lacking that would demonstrate obstructed airways. Again, it is preferable that the subject use a nose clip while performing the EVH challenge. Surrogate challenges to diagnose EIB should be considered based on criteria on this slide. Challenges may be direct, as with methacholine acting directly on the receptors, versus indirect challenge, in which exercise, EVH, or mannitol cause mediator release. Indirect challenges are preferred over direct challenges in this setting. Sensitivity and specificity for diagnosing EIB and diagnosing asthma will vary considerably depending upon which challenge is performed. Exercise in the laboratory versus exercise in the venue of interest should be considered to evaluate the patient in a very controlled environment versus the real world. The challenge should also be selected based on the ability of the patient to perform strenuous versus less strenuous exercise. A much more detailed comparison of the various challenges was published in the practice parameter for EIB. In summary, FEV1 is preferable over peak expiratory flow to assess obstruction because FEV1 has better repeatability and is more discriminating. Airway responsiveness is expressed as percent fall in FEV1 from baseline within 30 minutes post-exercise. The percent fall in FEV1 used to diagnose EIB is 10%. Severity of EIB can be graded as mild, moderate, and severe. A number of surrogate challenges for exercise testing have been developed, including EVH, use of hyperosmolar aerosols, and administration of dry powder mannitol or Aerodol. These surrogate challenges may be easier to implement than exercise challenge, but do not necessarily faithfully predict a positive exercise challenge. Thank you, and I hope your weekend warrior will go forth and be successful in his desired endeavors. Thank you.